DMSS. She is currently working as an associate consultant, cleft surgeon, and has operated more than 500 cases in the last 4 years. She has various publications in PubMed Index journals to her credit. We welcome you, Dr. Debolina. May I now request Dr. Debolina to introduce the mentors and start the program.
Thank you, Dr. Kalpa. Now I would like to introduce Dr. Manikandan sir. Sir is a pioneer maxillofacial surgeon. He completed his MDS in the year 1992. He is an FDS RCS England and FFD RCS from Ireland. Sir is the professor and director of Meenakshi Cleft and Craniofacial Center, funded by Cleft Children International, Zurich, established in the year 2003. Until now, Sir has treated more than 8,000 patients. Sir is also the Dean of International Relations in Mahir University. Can you see the screen, sir?
Yeah, you can start. Somebody has to keep moving. So,
wait 1 second.
Can you hear me very well?
Yeah, sir.
Can you hear me very well?
1 second, sir.
Yes, sir, we can hear you, sir. We'll be starting the screen show.
Thank you. That's
yes.
okay.
Yes.
Because that I am using my mobile, so that is why.
Okay.
I had a doubt because I couldn't carry my. I was thinking it is actually Sunday, so it is my mistake. I'm sorry.
No problem, sir.
Is the screen visible?
No, Dr. Debolina. It was visible earlier. You have to reach.
Okay.
Yeah.
Okay.
Yeah.
Now?
Yes. Just keep it in a slideshow. Yeah.
So the first question for today's cleft and craniofacial session is, what is the abnormality in orofacial musculature in the patient with cleft lip? Over to you, sir.
Thank you. Okay, so good evening all who are all present today. I just wanted to start this program by saying I'm sorry that I had a little time change of this thing, so I couldn't prepare myself. I hope that you can hear it well. Okay, so the musculature problem. Let us say that we have the orbicularis oris. So this orbicularis oris at the site of the cleft lip become completely separated. Is that clear what I am saying?
Yes, sir.
So it becomes completely separated. So we have 3 separate fiber groups in the lip that forms by the buccinator and oris muscles, which actually act like a modulator for the maxillary and mandibular growth, specifically the maxillary growth. So what happens normally in situations when there is you can see in the picture, the second picture shows very clear, the first picture shows very clearly how the continuation happens with orbicularis oris across the lip. So in the prolabium, in the muscles can start from one end to the other side, from modiolus to modiolus, which acts like a nice hammock, so that it controls the growth of the maxilla and also the growth of the nose. So it is a total 3D transformation. Suppose if the baby is born with a cleft lip, that continuation becomes totally defective. And you can see on the cleft side, on the picture on the screen, that this is a right side cleft lip. So you can see the part of this orbicularis oris going onto the lateral aspect of the nose. And the other part that is towards a non-cleft side is going towards the septal area. So here there is a total separation between the continuation of the muscles, and thereby it will not modulate the growth of the maxilla as it has to be. So that means the right half of the face towards the cleft can grow whichever the side it needed compared to the left side, and they can grow independent. That is why many of the patients get sometimes very wide cleft alveolus, and the nasal area get completely opened. And also sometimes the septal deviation happens, and the nasal cartilage can also get deformed. So the muscle is very important, and this muscle anatomy getting back to the normalcy during cleft lip operation is an extremely important step, because then only you can probably get not only a cosmetic result, but also functional result. When I say functional result, it has to be a combination of movement of the lip, whistling, expressions. All these lip functions are controlled by the orbicularis oris. So it is very important. These two cut ends of the orbicularis oris have to be brought back into position during primary cheloplasty or lip operation. And that will actually make the patient to grow both aesthetically as well as functionally back into the normal position. So that is very important. So that getting that three groups of muscles, superior and the middle and inferior towards the vermilion, into the right place. And that is why we need that dissection of the muscle during primary cheloplasty. The only problem happens in a bilateral. In the bilateral, what happens? The prolabial part, which is separate, may not have a muscle, which is not shown here. This is only unilateral. May not have a muscle. So that means in a bilateral, the muscle is restricted onto the either side of the prolabia. That is towards the cleft side, both the side. You have to dissect the muscle quite a long distance, bring it back to the midline, and try to get a connection. So muscle dissection, muscle anatomy, bringing back to the right position, sufficient. Without tension, you have to close it. Get the correct anatomy back into the position will help in getting both aesthetic as well as functional result. I hope this explains the function or the importance of muscle anatomy in cleft lip. Thank you.
Thank you, sir. We will be moving to the next question. Question number 2 is, what are the techniques to manage velopharyngeal incompetency?
Now, it is known that specifically in Asian and South American population, we have a problem that the length of the palate is always the problem. The length, when I say the width of the palate, means the distance between the two ends of the cleft palate we are talking about. Two ends of the cleft palate, that is a free edges. The same way, what we talk about the length of the cleft palate, that is means from the anterior most the cleft starts towards the uvular end. And in many cases, in Asian population and South American population, they found that there is a problem of having issue with reduced cleft palate length as well as the width. This is maybe related to the race origin, I do not know, but European counterparts and the other American counterparts, they say that their cleft palate is not as wide and short as what we see in Asia and South American. So whenever you try to close a cleft palate, you will end up in what is called as some deficient length in the posterior part of the soft palate. So now let us say that if there is a Normally when somebody speaks, or when somebody eats, or when somebody, trying to produce a swallowing, the soft palate have to raise against the pharynx posteriorly and produce some amount of seal. And the seal is very important. So if the length is deficient, you may get what is called as an incompetent. The posterior part of the soft palate is not touching the posterior part of the pharynx. And that is the whole problem is to do with it. That means during speech, other time issue, during speech, many of the sounds which are produced as verbal sounds through the oral consonants can actually, the air can escape through this incompetence into the nose and thereby produce a nasal tone, what is called as hypernasality. Hypernasality. Okay. The question now, what you do with it? The first thing we have to do is that how long did we operate this case? Normally, one says that a velopharyngeal incompetence must be addressed as soon as possible after minimum 1 or 2 years of primary palatoplasty. I'll tell you why. Because a primary palatoplasty, once done, the muscle function and the child will speak normally only starts at the age of 1.5 to 2 years to get with it. The more you do operation trying to push it back, the more scar will get in the soft palate. And it will be very difficult to repair after that, this scar, to remove it and repair it. And people found that it is better not to intervene till the age of 2 to 3 years for velopharyngeal incompetence. That is number one point. Number 2 point, the question now, where is the defect? Whether it is a soft palate level. So what normally one tend to do, you have to do a clinical examination, oral clinical examination. See how much hypernasality is there. You can do a certain test, see that, how much air is coming through the nose. And all this requires extremely important child help, or in an adult, their cooperation is very important. So in a childhood, correction of this incompetence become very, very, very crucial, because many of the moderate form of velopharyngeal incompetence can be corrected by means of speech therapy. It is not always that the incompetence need to be operated. I have seen in my own department so many cases of incompetence. Patient has a normal speech. Good speech, when I say good speech, there is absolutely no problem with the speech function at all. So that doesn't mean that velopharyngeal incompetence is not always an indication. If the speech is good, though there is an incompetence, you don't have to operate. Only there is a hypernasality, which is not getting corrected by means of speech therapy is one indication. Number 2, if there is a structural defect, which is checked by means of examination, you can do video fluoroscopy, lateral video fluoroscopy, and see how much of the soft palate is moving up and downward. All these tests can be done. Then one can perform some procedures to either to lengthen the palate by means of buccal pharyngeal flap, buccal flaps, or intravelar veloplasty by means of double Z-plasties. Or one can do what is called as orticochea pharyngoplasty, or one can do what is called as pharyngoplasty from the posterior aspect of the mucosa of the pharynx. That is from the posterior alone, I'm talking about it. So we have different techniques. How do we decide onto that? It is purely depend upon the morphology, what we see during the examination, including the velopharyngeal scoping. That is, you can put a small scope through the nose, have a look at it, depend upon the defect what you see, posterior, anterior, lateral wall defect, one can choose it. Thank you.
Moving to the next question. What are the landmark points for Millard's rotation advancement flap?
Right. Now, once you know that there is a defect, okay, once you know that there is a defect, it's all depend upon how much of a deficiency. You know, the problem is that we don't have 100% points to say, okay, this point will stay there and this is the length, everybody will have it. Every patient is a new patient. Everybody can have different dimensions and changes, rotations, deficiencies, length, height problem, all these things. Okay. So what you see here in this, very important, you can see 1, 2, 3. Okay. The cupid area, 1, 2, 3, the cupid, the midline of the cupid. 2 is the other side of the cupid and the 3 on the other side. Okay. The 4 on the non-cleft side, you can see the lateral alar area, extreme lateral area. 5 is the columnar area on the right hand side. And you can see the 6. Okay. 6, you can see 1, 2, 3, 4. That is onto the angle of the mouth. Okay. Now, what is important? You can see here from 6, you can go to the 7 onto the other side of that is the cleft side angle of the mouth. Okay. That is the junction between the upper and lower lip. You take it. 8 is the distance between 7 and 8. Distance between 7 and 8. Normally, that 8 point, what you're seeing is the white roll ends in the cleft side of the lip. Number 8. That is very important. Number 9 is the area where the cleft alveolus is there, where normally you will tend to see the mucosa, okay, of the nasal mucosa for joining with the alveolar mucosal area. Number 10 is the lateral cleft, lower part of the lateral alar area. That is the lateral alar area. The nose, 11 is the midpoint, and 12 is again another area which is very, very 3 important points which will decide how to bring back the nasal anatomy back into the position. Okay. So that is very, because I already told you, when you say cleft lip, please remember the deformity doesn't stays with the lip alone. The deformity goes into the nose, deformity goes into the ala, into the alveolus, everywhere. So it is not just the, we are looking into the exclusive cleft lip alone. Okay, it goes into the nose, it goes into the ala, the nose. So it is a complex deformity rather than an isolated deformity of the lip alone. And this is what is very important. Now, why it is important? If you look at it, see, distance between 2 and 6 should be equal to distance between 7 and 8. So this is what is very important to understand. Okay. Now you can see the point 3. Point 3. This point 3 normally after dissection is over will come in close contact with the number 8. You can see that. That is the continuation of the lip we are looking into it. And you can see there is a midline. Actually, there has to be a midline area, which is not shown here, but that is between the distance between 4 and 5. Okay, distance between 4 and 5. Can somebody put a pointer onto that, please? Yeah, you can see the distance between 4 and 5. Okay, that is the actual width between the lateral alar to columnar on the medial aspect of the columnar. That is the nasal flare area onto that non-cleft side should be equal to number 10. Okay, and on the 5, actually, there should be another marking on the columnar on this side, which is not marked. It should come there. So what is the symmetry? What we are looking here, all this landmark should bring 2 things very important. Number 1, height of the lip on the cleft, non-cleft side should be equal to the non-cleft side. Very important point. That means you have to rotate the non-cleft side, advance the cleft side. This is why we call it as advancement rotation flap. All these landmarks are designed accordingly to get the points back into the position. Okay, so two things are very important when you do a rotation advancement, because you are rotating, because the height between the point between 3 to 5 is, you can see that there. Okay, between height between the 3 to 2 into x, it is put there. Okay, you can see there. Can somebody point that into that? 2 into x. Okay, number 2 point.
Sorry, sir.
Something wrong?
Yes. Okay, sir.
Sorry, number 2 into that 1 point, x point, it is written into point there. That is the length. That is actually the length of the non-cleft side of the lip. You have to get the same length between 3 and up to that distance of the columella on the left-hand side. So that's a shortage. You have to rotate it. So when you rotate it, what will happen? It will tend to lengthen the lip. The same way you have to advance the non-cleft side. So all these landmarks are decided for the purpose of getting the symmetry between left and right side of the cleft lip, and also the height of the cleft lip between the cleft side versus non-cleft side. Thank you.
Very beautifully explained, sir. Moving to the next question. How to select between VY pushback, 2 flap, and von Langenberg palatoplasty?
Good. Now, can you put a picture there? Yes, you can see a picture pushing it back with technique. You know how you can really do it. I think it is a very difficult question to answer, because it's all the initially when everybody started doing cleft palate. I already told you that the intention was to push the soft palate as back as possible, because all of our aim should be to reduce the velopharyngeal incompetence. So the more you push it towards posterior aspect of the pharynx, everybody thought that is the best you can do it, because if you can reduce the velopharyngeal incompetence, you get a better speech. That is the general concept everybody agreed from day one. Then what happened? At the end of the day, everybody knew how the soft palate is moving because of the muscle. So it is not just the surgeons understood that after some time. It is not just the pushing the whole hard and soft palate backward is not the end of the story. The story lies in how effectively you can make the soft palate to raise against the pharynx. How it is possible? You have to do what is called as a muscle repair. Same like cleft lip repair, you have the muscles, levators, tensors, uvular muscles, palatopharyngeus, palatoglossus. This group of muscle have to be between the left side and the right side have to be brought into position. And that is what is very important. So many people may not even choose a good VY plasty nowadays. If one can do a good 2 flap technique with a very good muscle closure, if possible under the microscope or with a loop, if I can do a very good muscle closure, even if there is a little incompetence, it is not a problem in many hands. Because what happens, even if there is an incompetence, I already started with that when I started with that. My presentation that if the speech is good, incompetence is not an issue. Please remember, if the speech is good, incompetence is not an issue at all. So that means if we can get a closure without fistula, number one, with a good muscle closure, and that can bring about a good speech, you can probably choose what is called as a 2 flap technique without any trouble, specifically in, again I'm repeating, specifically in unilateral cleft lip, yes, palate, and incomplete cleft palate. 2 flap technique is more than enough. Rare cases of wide cleft, bilateral cleft palate, you cannot do a two flap technique. You may end up in mostly into a V5 pushback. Because you have to get that pushback and bring it in the midline and all those things. All forms of Velopharyngeal, when you push it back, remember, you will get definitely some amount of anterior defect. This anterior defect, okay, this anterior defect, somebody can point into that, okay, this anterior defect in Velopharyngeal will lead into a secondary defect. Scar formation can happen. Maxilla will not grow. Most of this patient will end up in hypoplastic maxilla. That is why the two flap technique, which is just raised on either side and closure with a muscle closure, good muscle closure, is a better chosen option in many surgeons' hands. Thank you.
Moving on to the next question. Which one is preferable between primary and secondary alveolar bone grafting technique?
Right. Okay. So most of you know that what is a bone grafting is all about it. So here, when you say bone grafting, primary bone grafting means you have to do the bone grafting at the time of primary keratoplasty or a palatoplasty, which is sometimes it is at that age is not a good option. But when I say somebody says primary palatoplasty, normally what the meaning of that is that it has to be done at the time of the repair of the lip. So that means at the age of 3 months or 6 months, or maybe 1 year, depend upon when the child present to you. The problem comes that you have a wide cleft alveolus. You may not get a good mucosa to mucosa closure on the alveolus. You may not be able to get that seal there, and you cannot put something there and try to close it like that. So primary grafting normally is performed by means of a soft tissue repair, what is called as gingivo-periosteoplasty. That means if we can get your gingiva from the cleft side to non-cleft side 100%, you expect some bone formation under this gingiva, under the gingiva periosteum. By reducing the cleft side and bone formation, which has been proved in many studies, they do a radical gingivo-periosteoplasty. You can bring it from the non-cleft side, you bring to the cleft side, do a good closure of the cleft lip. Many times they found that the bone can form in between. It may not be 100%, but many of them end up in what is called as a secondary bone grafting. That is done at the age of between 5 to 9 years. And that is, as of today, that is still the gold standard, secondary alveolar bone grafting, because which is done to make the maxilla, right and left side of the maxilla into one piece, because otherwise the cleft lip, cleft palate, cleft alveolus will make the maxilla into two separate, unilateral one, two separate. In bilateral, it will be the maxilla into 3 pieces. So you have to bring the whole maxilla into one piece for the purpose of growth, for the purpose of, sorry, I think some disturbance from the side. Yeah. So for the purpose of growth, for the purpose of bringing the tooth lateral or canine back into that position of the defect, it will, if you're putting a grafting into the secondary alveolar grafting in a very nice way, will also lift up the lateral nasal sill area, that is the lateral alar area. So there are so many functions of secondary alveolar bone grafting, and even today, from the age of 5 to 9 years, maximum 10 years, is still considered as the gold standard. You can take bone from the iliac area or from the tibia, you can take it trifine and you can take it from anywhere. Any of this graft can be used actually. So it's very important to understand that the growth of the maxilla, making it one piece, allowing the tooth to grow, support for the lateral nasal area, all these things are possible only with the excellent secondary bone grafting.
Right, sir.
Thank you.
So our next question is, Mechanism and advantages of nasoalveolar molding in cleft lip and palate patients.
I think we are coming ulta. We should have done this question first. Yeah,
Yeah.
doesn't matter now. But I have. See, I have started with that first. That can you put that slide from the first one? That is the muscle anatomy.
Yes.
Can you go back to that slide again? Muscle anatomy slide, please.
Yes.
If
Yes,
I
sir.
show you there is a defect, the nose become defective. The muscle. First question, I think that was the.
Sir, I'm displaying that slide.
Can you go back to that? In a couple of minutes, I can finish it.
Sir, I'm displaying that only.
First question, yeah. Then there was a picture in that. So,
Yeah, sir, I'm displaying that slide.
Yeah.
Is it visible?
Yeah. Now we are okay.
Okay.
Now we are okay. Yeah, we are okay. Now you can see in this slide, the affected side of the nose become defective. Affected side, they become white. The cartilage become defective. And remember, I told you, when you have two separate group of muscle towards the cleft side and non-cleft side, they try to pull it on either side with not having a complete seal over the lip. So the nose get deformed. So when the nose get deformed, including the cartilage, we try to do best during the cleft lip operation. But a deformed nose or a cartilage is very difficult to correct. You can try to keep your ear cartilage, all of you can feel it, how flexible they are. But you try to keep it flat or try to hold it, bend it. Even if you hold it for 1 year, if you leave it, it will go back to the same position. That means the cartilage, once deformed, specifically in the ear and the nose, is very difficult to get it corrected. You cannot get a normal anatomy shape back. So in order to facilitate this deformity before the cleft lip itself, closure itself, many of them started doing what is called as nasoalveolar molding. So that means it can mold, it can change the shape of the nasal cavity, number one. It can bring the two alveolar part from the cleft side, non-cleft side together. So lesser the defect, better the result of the cleft lip or palate operation. Not only lip, but also the palate. Remember that. So nasoalveolar molding, if one can perform in a very nice way for first 3 months till we do the first operation of cleft lip, will definitely help in the form of getting the shape of the nasal anatomy in a very nice way. Only thing you need a good impression. You have to know how much pressure to be given, what are the techniques normally involved with it. Okay, many of them say that nasoalveolar molding produces immediately after surgery. Some of the long-term result, if they see, you can probably avoid a secondary rhinoplasty when the child grows completely into an adult. And that is what the importance of nasoalveolar molding. Immediately 1 or 2 days after the birth, you make a feeding plate or whatever it is there, or without feeding plate. If you can make a palatal plate with a nasoalveolar molding device, it helps in modifying the nasal anatomy. It lifts up the nasal anatomy. It can bring the alveolar bone together for a better result, and you can do a wonderful lip surgery that will actually helps in probably completely eliminating a secondary rhinoplasty in the child in the late adulthood or adult stage. So if possible, in short, if there is a feasibility, patient can come regularly, and if it is feasible, every surgeon should get trained in it, and please do it. Definitely it will produce a change. Nasoalveolar molding. Thank you.
Moving on to the next question. What is the difference between Pierre Robin sequence and syndrome?
Yeah, sequence, you can see there. everybody knows it is a syndrome is nothing but two, or more abnormalities coming together. We normally call it as a syndrome. Sequence is what is developed from the birth to, as the child grows, and there is a series of changes which are happening. So I think a syndrome, you can see there, the retrognathia, glossoptosis, that is a short mandible. The size of the tongue itself becomes small and goes backward with a cleft palate. Okay, and that is the problem in the Pierre Robin sequence. Normally, that will end up in what is called as difficulty with the breathing and obstructive sleep apnea and all those things. Okay, so that is one thing you have to understand, that the micrognathia, the glossoptosis, small tongue which is posteriorly pushed, because when the mandible becomes small, the tongue cannot develop. When the tongue cannot develop, when the mandible is small, when the baby is sleeping, it can fall back into the pharynx, and the pharyngeal space becomes so narrowed, you will get lots of problems, including the difficulty in breathing and other things. So that is what is very important. And normally, there are different techniques, including distraction of the mandible and other things, including lip, tongue adhesion. All these things can be performed in a very simple way, so that you can improve the airway, improve the tongue can be brought forward by means of it. Mandible can be stimulated growth by means of distraction from the day one. Different centers, different countries follow different protocol. But I think majority of the centers are now moving away from distraction. They are going more towards other techniques, including tongue lip adhesion, which is more than enough for the patient to grow the mandible and the tongue as it is.
Moving to the last question of the Cleft session. What are Goldenhar syndrome and hemifacial microsomia?
So I think it is microsomia, we know. Hemifacial means one side of the face is not growing. Okay, so you can have a deficiency of asymmetry. One side is different from the other side. You can have ear problems, or issues of ear, half ear, sometimes rudimentary ear, sometimes there is no ear. Hypoplasia is very common with it. Facial nerve problem can come, hearing problem, ear tags, cleft lip and palate. All these things are very common with hemifacial microsomia. And sometimes you can have abnormalities of the eyes area. The eyelid can become a problem. The cheek muscles can become, because of these issues with the facial nerve, can get these things. So, of course, there are different degrees of problem, mild, moderate to severe form of hemifacial microsomia. And most of you know that there is a classification for it. So that is a little different from the Goldenhar, which is actually in the past they used to consider as the same spectrum. But the problem is that, can you go back to the next one? Yeah. Here, there is an underdeveloped facial muscle which may be associated with the weakness, microtia. You can have bilateral sometimes. Okay, cleft lip and palate, and lot of other abnormalities, including retinal abnormality, vision loss. Okay, and you can have abnormally large mouth. That is a lateral cleft. You can have it. Okay, all these issues can happen with Goldenhar syndrome. And remember, a Goldenhar syndrome also associated with hearing loss, hydrocephalus, intellectual disabilities, problems in kidneys, lungs, and heart and spinal deformities, which is a much more a bigger complex problem compared to a simple hemifacial microsomia, which is a much more simpler one. So there, the systemic involvement in Goldenhar is much more higher in comparison to hemifacial microsomia. You can have even 10-degree, 20-degree problem only in the face with hemifacial. But most of the Goldenhars are quite severe. They can have other systemic pathologies and involvement as well.
Thank you so much, sir.
Thank you.
Thank you for your precious time. All the questions are so beautifully explained. I think this will be very much helpful for the exam going PGs.
Thank you.
With this note, I would like to conclude the Cleft session, and we will be moving towards the cosmetic surgery session. Dr. Kalpa, may I start the next session?
Yeah, sure, Dr. Debolina.
Okay.
Dr.
Our mentor for the cosmetic surgery session is Dr. Yasser Arafat. He is on BDS, MDS, MOMS RCPS from Glasgow, FFDS RCPS from Ireland. Sir is a fellow in head and neck oncology and reconstruction, fellow in oral implantology, fellow in facial cosmetic surgery and hair transplant. Sir is an experienced oral and maxillofacial surgeon and member in Royal College of Physicians and Surgeons of Glasgow and Royal College of Surgeons of Ireland, and in addition got training in oral cancer, ablation and reconstruction in RGGH surgery onco unit for more than 3 years. With over 12 years of experience in performing orthodontic surgeries, hair and neck tumors, oral and maxillofacial trauma, cosmetic facial surgeries, hair transplant, and dental implantology. In addition, he is consultant OMFS for MOH Oman and MOH Abu Dhabi. Over to you, sir.
Yeah, thank you, Debolina. And you're going to share the screen, or may I share the screen, or how it is?
Sir, whichever you say.
Okay, can I share my screens?
Yes, sir.
Yes. Is it visible?
Yes, sir.
Okay. After a
I will
wonderful,
read out the questions, sir, for you.
Yeah. After wonderful sessions by my one of my prof, Professor Manikandan, and I'm going to take you to another session, another elaborate session of cosmetology or aesthetic surgery, where most of our PGs are unaware of it, or the subject is, especially in our maxillofacial, is upcoming or in existence in a current PG curriculum. So I just want to explain a few aspects where there is a few questions. In that, I'm going to explain mostly about the facelift and blepharoplasty. Other few questions are usually the normal questions, but I try to cover that also. Yes, Debolina?
Yes, the first question for the session is tapered technique for smash rhytidectomy procedure. Over to you, sir.
Yeah. The rhytidectomy or the facelift, the most common type we follow is smash lift. And the other thing is deep plane facelift. Very few instances we do skin only lift, but it has an inconsistent result. Now they're coming up with the latest one is mini facelifts, where we do an isolated facelifts in an isolated area, and a minimal surgical intervention for even a 30s or 40s patient. We do a thread lift. That is the one which is done in a dental office itself. So now there is advantage and disadvantage of the skin only lift. The skin only lift, most of the surgeons, especially the cosmetic people or the people who are following the aesthetic surgeries, are not doing because of its unaesthetic and windbone appearance and short-lived result. The workhorse of facelift you can follow is the smash plane facelift that gives a very good dramatic result with long-term outcome. And the smash plane can be plicated, or it can be, we can do a smashectomy, or we can reposition. A lot of things we can do. The biplane facelift, we need a lot of expertise, and you need a lot of surgical training in that to manipulate around the facial nerves. D-plane in the same way, it is also a little tricky because we manipulate around the facial nerves. Mini facelift, of course, we addresses small areas. We're not going to cover today because short of time. And subperiosteal facelift is just for the ptotic muscles, where it is more of a book procedure rather than a clinical procedure. So facelift, we need to know what I'm going to talk is mostly about a smash lift or only about the smash lift. So we need to know the basic anatomy of the face to understand the smash lift. The first layer is of course skin, followed by subdermal fats, and second layer is a subcutaneous fat layer, which is always the addressed in the facelift, and it is the most safest way to dissect. It's above the smash plane. The smash plane, in reality, is it's like a fibromuscular tissue which lies above the parotidomycetic fascia and below the subcutaneous fat layer. So it's actually physiologically a smash is nothing but it's a transition zone of fibromuscular tissue which carries the muscles of facial expressions to the skin through a septae of connective intervening tissues that transfers the action of the facial muscles to the skin. The smash layer is the plane which is to be addressed in facelift. The subsmash plane is usually contains a facial nerve, all the facial nerve branches and parotid duct. So to understand it clearly, you can see this one, this slide where a pointer is there. It's the smash plane, which is above the parotidomycetic fascia, is the extension, nothing but the extension of superficial layer of deep cervical fascia into the face. So when it travels above, it continues as a extends to from the anterior border of the parotid to the anterior border of the masseter. That is subsmash loose alveolar tissue. So so you need to understand this. The smash plane is nothing but the extension of superficial fascia into the face, superficial cervical fascia into the face, which will be fibrous in certain area and muscular in certain area, which continues upward as temporoparietal fascia and to the galea into the scalp. So whatever the facelift you address, we talk about only this smash plane from now on. So armamentarium, you can get it from anywhere, but we need certain important thing like a blunt cannula with the trocar and certain other things like tenotomy scissors and all these finite scissors we need to be carried. So 10-step smash rhytidectomy is the one I'm going to explain now, but there is no strictly you need to follow the 10 steps. Actually, it's a 6 to 7 steps, but you give 10 steps, it's like you give a good result to the patient. So first is obviously tumescent. Tumescent is a must for any of these cosmetic procedure, as it's more like a hydrodissection of the facial planes. So these are pictures where we need to give how much the volume of the tumescent need to be given, as been explained here. And next is using a stab incision going into the subcutaneous plane to do something called as the face and neck liposuction. Initially, we need to grossly do a facial and neck liposuction with liposuction needles, and we have to address the neck as well as the face. The third is especially for the older patient. If it is going to be the younger patient, we can skip this procedure, especially the platysmoplasty. Where it is more obvious the hyperactive, the platysma, which causes a hooded sort of appearance in the chin, which gives more age changes. And for older patients, we need to address this. Especially, we need to give a good result. How we do is give a small a 2 to 3 centimeter incision into the submental fold, and there you have to do a blunt dissection. You have to go supraplatysmally, grab all the fibers of platysma from both the ends, and try to run a continuous stitch from both the ends. Okay, what are the incisions? This is the basic, very important steps in facelift is facelift incision. Usually, he has to follow the lobule of the ear like a curvilinear fashion. It has to go like it is nothing but a preauricular incision it should follow in a sharp angle around the ear in a pre-auricular as well as post-auricular incisions. The important point note down here is when it comes to the hairline, it should follow the pattern of the hair follicle. The hair follicle, how it the incision should follow the hair follicle, especially in the side region of the hair as well as in the post-auricular region. And next is the hairline incision should be with the bevel. It should be at a 60-degree bevel so that it has two advantage. And it should not be a straight line incision. It should be something like doing a W-plasty, so that we are giving a V cut or a W cut. So then when you're approximating, the wound will be near normal, and once it heals, the scar contraction will be minimal. Plus, additionally, you have that hair follicle in the transected area will grow, and it will seal that area in a natural way. You can see in the right side there is a picture where the wound, the area is healed in a good way. So this is the within 1 week of 1 week picture of SMAS facelift, and you can see after 3 months there is a significant there is no scarring anyway, it is not visible. The step 5 is dissection. So here you use a blunt trocar like cannula, and you put it in the subcutaneous plane, and we try to separate. It's like separating a skin. So this is the important step is we should not take all the fat away from especially from the skin side, because if you take it, it'll become so thin and there will be a dehiscence of the skin and there will be a bruising. So the skin has to be cushioned with fat. So there should be a fat underneath the skin as well as over the SMAS plane. That is a very important step in dissecting, before dissecting this procedure. So treating the SMAS, this picture clearly, you can see the clear picture. The SMAS in the face continues up as a temporalis fascia and to the scalp as a galea, and in the neck as a superficial temporal fascia. So our aim is to pull and in a vector, in such a vector that so it get anchored and the face is lifted in a good way. So step 5 is treating the SMAS. SMAS, either you don't do treatment, especially young patient where you address only the skin, or you do a SMAS plication. But plication is a problem is you see that sort of a redundant that pliked area after healing with a little elevation in the preauricular region. So this is also not good. So deep line dissection, really you need expertise to do that, and it's not an easy until you get mastered of the facial planes. So SMASmectomy is the workhorse. What we do in SMASmectomy is we do an inverted L-shaped a small portion of the SMAS has been trimmed off and reapproximated and in a vector such a way that it should be posterior as well as superior. It should not be posterior. I'll come to that later in my slide. You can understand better. So next is wherever there is an excess fat, you can, while clinically you can see, and you have to make it an open liposuction, and you have to remove, especially in the submental region where there is a accumulation of fat, especially in the ages, once a patient ages. So that has to be addressed. Posterior platysmal suspension, this is not always we do, especially this we do only for old people where there is a hyperactive platysma which is really obvious stitched to the skin. So in that case, we have to suspend the posterior aspect of the platysma with the same incision, post-auricular incision, the superficial fascia over the behind the lobule of the ear, and this we don't always follow it. For completion's sake, I have faced this. So managing excess skin, this is very, very important steps. For this, we have to see the direction of pull is very, very important. If you can, the first picture is wrong. First picture is absolutely wrong because you pull it towards the scalp, it gives a wind-blown appearance. Even the second picture, we follow mostly second and third pictures because the posterior pull, which gives a good jaw line correction. Jaw line, it gives a nice approximation of the jaw line with a nice contour of the mandible, as well as one pull towards little superior and posterior. It all depends on the clinical situation as well as the excess skin where we are going to trim. See, the important stitch is two key stitches. That is, one is in the root of the ear, where this stitch determines the excess of tissues which is going to be approximated in the hairline. One more is post-auricular incision near below the lobule, where we give a cut and we're going to put two stitches, important stitch, one in the superior aspect, one in the inferior aspect. In between, you have to contour. That contouring comes once you do regularly, and it is a slow learning curve. The final skin sutures I do with a resorbable stitch, so we get resorbed. You can see that most of the post-auricular incisions hidden inside the hair follicle, as well as we give a bevel, so that the hair once it heals, it drapes around the incision and it gives a very pleasing or unsightly scars. There will be a good looking scar which is hidden in most of the time. And along with that, we do something called as laser resurfacing of the skin, so that the excess, even the people doesn't have the problem in the dermal level also. They have dermal level or few cell deeper to the dermal layer. So we do at one time the CO2 laser ablation of the skin at the same time also to give a good result. So this is without compression dressing. There'll be an edema and all the problems. So this has to be addressed with the compression dressing has to be given. So that comes the steps in facelift rhinoplasty. Yeah. Next question.
Thank you, sir, for sharing so many clinical pictures. Now it will be more easier to understand. Moving on to the next question. How to choose between open and closed rhinoplasty?
Yeah, the contemporary view of rhinoplastic technique is an either endonasal or closed or external approach is based on indications, technical consideration, and individual comfort and expertise. The indication, obviously, for open rhinoplasty, if there is a gross deformity, asymmetrical tip or wide and bifid tip, cleft lip nose has to be addressed with open rhinoplasty, badly twisted nose, severely saddled nose, some revision rhinoplasties. Very minimal indication for closed rhinoplasty. If you want to do a delicate tip rhinoplasty or juvenile rhinoplasty, moderately saddled nose, or some revision rhinoplasty. A moderately saddled nose, we can give a filler and we can correct it with closed rhinoplasties. Next question.
Next question is, what are the indications for dermabrasion?
Dermabrasion. It's like you're removing a layer of skin. The dermal layer. So whatever the ablates, it's like ablating the skin in the mid-dermal dermis. The condition which involving the structure above the level in the skin are typically amenable to the treatment. We do dermabrasion, especially in acne scars. Post-acne pitting and box scars is ideal treatment for dermabrasion. But dermabrasion alone will not treat the problem. There is a lot of added technique like dermabrasion, RF dermabrasion with RF needling as well as dermabrasion, along with PRP treatment as well as some sort of additional measures will give a good result. But basically, in a clinical setup, acne scars and actinitic problem, that is the way we do a dermabrasion. And other indications are post-scar revision, along with, if it is a minimal scar, we can go for CO2 ablation, along with dermabrasion with PRP treatment. It gives a nice result. As well as for age-related skin resurfacing problem, we can give a dermabrasion. Yeah, next.
Thank you, sir. Our next question is anatomy consideration for a lower blepharoplasty.
Okay, this topic I'm going to elaborate because I just love this topic because most of the time I've been landed either with a traumatic correction or blepharoplasty. We need to understand most of us are not much familiar, even myself for a couple of years before, until I see and I get a proper orientation. So other structures of eyelid, I mean, the globe, like the cornea, sclera, or whatever it is, the iris, and all these things, But the area of concern for blepharoplasty is we need to understand about the orbicularis oculi muscles, how it is draped around the eyes, and it has a three component like pretarsal, preseptal, and orbital part. So next we need to understand about something called as orbicularis oculi fat, roof. Roof is, it's a retro, that means it is behind or beneath the orbicularis oculi muscle, but it is not evenly distributed. It is distributed in certain areas. Next is orbital septum. It's nothing but an extension of periosteum. Next, we need to note about the orbital fat pad. That is a workhorse of most of the cosmetic. I'm telling about the cosmetic blepharoplasty, not the function. And lacrimal gland, of course, you know, it's in the lateral aspect of the upper eyelids. And superior oblique muscles, which is we need to know, because when you need to know, we need to trim the excess, the orbital fat. We need to know about this muscle. The levator palpebral superiorus, as well as its upper neurosis, which we need to know, as well as you need to know about the Muller's muscle, which is 2 mm, which is autonomic muscle of the upper eyelid, which causes 2 mm opening of the upper eyelid. Structures of the lower eyelid is similar except for the lower eyelid has a lower lid retractor. This is a palpebral fascia, which is an extension of inferior rectus upper neurosis. If it is a lower eyelid, then we need to know about SOOF, suborbicularis oculi fat. And lower eyelid, the fat is concentrated unless like an upper, where is a middle and the central compartment. Here it is separated by the inferior oblique by medial, central, and lateral compartment. And need to know about inferior oblique and orbital rim. So you need to know much about SOOF and roof. You can go through this article. It's from Korea, and they compared a cadaveric dissection of a few patients, and they arrived at the conclusion that roof and SOOF are situated deep to auricular. It's nothing but, and it's more of fibrofatty tissues, and there is a age-related changes in that we need to be addressed during the cosmetic blepharoplasty. The roof, which occupies an horizontal, width of around 2/3 of the width of the orbital volume, as the 1/3 of the width of the vertical height is 1/3 of the width of the orbital volume. Similar way, the SOOF is like L-shaped thing, which is more of lateral to the near the zygomatic area of the orbicularis oculi muscle. Okay, and for eyelid, we need to know about the 3 lamella. The 3 lamella is the outer lamella, which is skin and orbicularis oculi. It is arranged in 3 lamella. You can see. So this first lamella is the skin and orbicularis oculi muscle. The second lamella is the orbital septum and its fat content. You see here, the orbital septum, which is nothing but the extension of the periosteum, and it holds the orbital fat. As we age, what happens that you see, if you carefully dissect even for your floor fracture, a traumatic case, you carefully dissect the orbicularis oculi muscle, you can see a glittering surface beneath the orbicularis oculi, especially in the preseptal region, that is called as an orbital septum. The septum, which is more like an inguinal area as compared to the other anatomical aspect, it holds the orbital fat tightly packed. As we ages, the elasticity of this drastically reduced, and the orbital fat prolapse. It's not herniate. The right term is prolapse. So it prolapses either into the infraorbital region, or especially for lower eyelid. And in upper, it will be prolapsed in the supraorbital, the skin creases. So inner lamella, which include tarsus and conjunctiva. So orbicularis oculi muscle, as I mentioned already, this picture is for you to understand where you're going to operate for a lower lid blepharoplasty. So orbitalis oculi muscle has 3 components: pretarsal, preseptal, and orbital. So once we open it, we can see there is a glittering surface not seen properly here. The fat started to herniate. So we need to know about something about tarsus. Usually the upper tarsus is crescent shaped and it is 10 mm in height. Lower tarsus is just 4 to 5 mm in height. In Caucasians, especially in the Caucasian females, it is 10 to 12 mm and in males it is 8 to 10 mm. The upper eyelid creases especially for the Caucasians. For the Asian is 4 to 6 mm, because the levator aponeurosis is positioned more inferiorly. So your selection of cases is very, very important prior. So I already explained about the periorbital fat. So the globe is cushioned by periorbital fat, as all you know. Reduced or repositioned in cosmetic, this is the one which is being reduced or repositioned in cosmetic blepharoplasty most of the times. An additional procedure like excess skill trimming and all comes later. Fat pad in the upper eyelid in a 2 compartments, separate like medial or nasal, central compartment by superior oblique muscles. Whereas the lower, it has a 3 compartments separated by inferior oblique. One is medial, which is nasal, central, and lateral is called temporal. So whatever you're going to do, we have to pre-op, we have to investigate where is the problem, and you have to open that compartment and we have to do the procedure. You don't need to know about this, but as a completion sake, I have mentioned about the nerve supply of the orbit. The sensory nerve, of course, of the entire face is trigeminal, and especially except for the lower half, which is where the cervical plexus there, and upper lid, the retraction is done by levator muscles, and levator muscle that is alone supplied by oculomotor, and Muller's muscle is, of course, autonomic muscle. Eyelid closure is by 7th nerve, and other extraocular muscles, LR6, SO4, that is a mnemonics we studied from from your UG days. So next topic, yeah.
Yes. Next question is, what are the contraindications for hair transplant procedure?
Yeah, hair transplant. It's actually I've been doing for quite number of years, and it's a mixed response, to be frank, because initially I don't know how to select the candidate, and while we should see, we are doing hair transplant, we should be like a medical professional. We need to know, investigate the patient, work up the patient in a proper way. So hair transplant, you need to know about their history. Either it can be a fever or pruritus or inflammatory conditions or excessive bruising, scratching. Medical history, you need to know about the thyroid history, diabetic history, autoimmune diseases, or like HIV or lupus or malnutrition, vitamin mineral. So most of them, they fit under the vitamin and mineral deficiency. You have to work out and you have to correct the nutrition before you do some sort of attempt to regrow or transplant the hair. And medication history, you have to take psychological assessments, stress and anxiety disorder, which is which need to be addressed, because most of them, they don't give importance to that. It leads to a metabolic problem, which in turn leads to a hair loss. Physical examination of hair, like positive pull test and all these things, you have to be addressed before selecting the candidate for hair transplant. So we need to do a scalp biopsy or cage preparation to rule out any inflammatory or infectious origin, and even for a fungal infection of the scalp before doing a hair transplant. Next, yeah.
And last question of this session is, what is Gateplasty and Wplasty in scar revision?
Yeah. Okay. See, Zplasty, it's nothing but creating a 2 equilateral triangle of 60 degrees. And there will be 3 incisions, one A to B, C to B, C to D. So what happens? The C will go to A and B will come to D. So what is the basic idea of doing this is, you're breaking a linear scar into a small scar which is spreaded. So that is the basic idea of the Zplasty, and it has to be 2 equilateral triangles approximated, and it is transposition as well as advanced. It is like more like a rotation as well as advancement of the 2 flaps. So we routinely do this. I've been working in an oncological unit, and post revision oncology surgery, I've been routinely doing this procedure. What is advantage is reorienting, of course, reorientation of the scar. It lengthens the scar, irregularization of the long scars, no or minimal excision of the normal tissue. No need to excise much. We can just reorient it. That's it. Limitation is self-evident. It is evident, and 3 times a long original scar will be created. and 2 additional scars will be created. 1/3 of the scar will not be in a relaxed. This is an important point to be noted. It will not be in a resting skin tension line. So what is Wplasty? This procedure to prevent the contraction of straight line scar in which the edges of the wound are trimmed in the shape of W and closed in a zigzag fashion. I go back to my old slide as during my hair, rhinoplasty facelift procedure. When you're giving an incision in the hairline, I use this procedure because it gives these, it prevents the linear scar formation. And there is a linear scar, the hair will not grow in that area. And plus, we see the hair follicles, you can see the hair follicles, orientation of the hair follicles, and you can give an incision. And the other hair follicles, we can just, wherever the hair follicle is, it's curving or turning, we can change the incision so that when you're approximating, it will be beautifully oriented and there will not be any hair loss in that area. So what is the advantage? Easy to plan and construct, break up a linear scar into a small segment. Many of them runs parallel to resting skin tension lines. So it gives a more pleasing and appearance. Limitation is Wplasty is that it creates a scar that has a regular repetitive patterns and more noticeable. But you can give it where you can give in the hairline areas, and in the areas other than part of the small scar can be given, and in other part of the body. Wplasty techniques works well for shorter scars, but it is not suited for the long facial scars. Thank you.
Thank you, sir, for such elaborate presentation. I hope it has cleared many doubts of the students. Thank you for taking your time out for us.
Thank you.
And before ending the session, I would like to thank Venil ma'am, Jameson sir for choosing me to be the moderator. Thanks to Dr. Kalpa for your continuous support. I wish my best for the upcoming sessions. Over to you, Dr. Kalpa.
Thank you, Doctor. Thank you, Doctor. As we come to the end of the session, on behalf of Tamil Nadu ABO MSI, we would like to extend our heartfelt gratitude to the mentors and moderators for the valuable contribution and sharing the knowledge. Now, the participants are requested to stay connected to fill the Google feedback form that is posted in the chat box. Filling up this is mandatory for your certificates. Please fill up within 10 minutes. Thank you, Dr. Manikandan sir, Dr. Yasser, and Dr. Debolina for a very informative and excellent session. Thank you all.